Good evening, everyone. On behalf of the Clinical Research Forum, Federation of Clinical Pharmacists in India, I warmly welcome you all to today's basic module session titled Case Reports and Case Series. We apologize for the delay in going live because of the technical issues. And without further delay, I would like to introduce Ms. Amartya Sriracha, Co-Lead Clinical Research Forum, FCPI, who will be guiding us through the fundamentals, structures, and significance of case reports and case series in clinical research. She has ample experience in writing case reports, so I think she will be the ideal choice for today's session. Now, I invite Ms. Amartya Sriracha to begin with the session. Over to you, Amartya.
Thank you, Harita. Thank you for the introduction. And good evening, everybody. Let's dive into our today's session, which is uh, case reports and case series in clinical medicine. So, in this session, we are going to learn how they are the ideal to beginning your research journey because they are relatively easy to publish and they provide valuable exposure to the entire process of manuscript writing, formatting, and journal submission. Our objectives for today's session are to understand what case reports and case series are and the differences between them. A clear understanding of the definition will help us identify suitable cases at the bedside and transform them into research publishable research articles. After understanding this, we'll move on to the purpose. That is how these case reports and case series contribute to the evidence-based medicine. We'll also explore the strengths and weaknesses. Finally, we'll learn not only how to write case reports and case series, but also how to critically evaluate published articles for quality. Beginning with the definition. One case report is equal to a one patient scenario. That is, these case reports describe unique, rare, and novel medical scenarios in great detail in relevance to the existing literature. So, these are the cases that are beyond the guidelines. The patients are the outliers who are not generally present in the large trials. These are the patients that we see in our day to day clinical care. The patients with multiple comorbidities, drugs, with unique presentation syndromes, in whom we do unique interventions like use of a different diagnostic approach or a treatment approach. These novel cases become case reports. As I mentioned earlier, that is why it makes them a smallest piece of publishable unit of medical literature because it's just one case of a single patient. Now that we have understood what exactly is a case report, let's move on to what is a case series. Like you see in the image over here, it's multiple patients and there is some common point that is connecting all of them. So, case series is generally a group of patients with similar diagnosis. But how many cases make a case series? We don't know actually. It is unclear. Some authors stick to the rule of four, saying that four cases make a good series. But anything more than one case is a case series. This is what is the basic difference between case report and the case series, which is the sample size. The findings of a case series are stronger than the case reports mainly because of these sample size. When examining if there are more than 10 cases, it enhances the research statistical relevance and reliability. So, at the baseline, a minimum of 2 or 4 cases makes a good case series, and a 10 cases will make a statistically sound case series. So, that is the basic difference. These are the novel cases. One case will make a case report. If there is a more than one, then they become case series. This is all is about the definition. Now let's move on to the purpose. Why? Why do we need these case series and case reports? As you can see here in our evidence-based pyramid, they are mostly at the bottom. They are at the bottom over here. And they are not the strongest form of evidence, that is, randomized controlled trials or the systematic reviews or the critically appraised articles. So, why? Why do we need these case reports and case series? Because Randomized trials, these the highest form of evidence like systematic reviews, deal with population of patients under carefully controlled conditions. Whereas case reports and case series deal with individual patients whose purpose is to provide us the information about novelty, new ideas, fresh hypotheses, and therapeutic surprises. As you can see here, they give us the novel insights, that is, unique perspectives on patient scenarios that lead to groundbreaking discoveries. They help in hypothesis generation, which ultimately leads to the foundation of the trials. And very importantly for us, the PharmD, the clinical pharmacy community, they play an integral role in pharmacovigilance, that is, to identify real world adverse effects in different patient population. This is how case reports can lead to clinical trials. Here is a classic example of the whole thalidomide disaster that has happened. It began with few clinicians noticing the adverse effect that has happened, the toxic effect, the phocomelia, and then resulted in a detailed study of the adverse effect in animals, and then the drug being banned. So this is how a single clinical scenario or a single clinical observation can result in generation of an hypothesis. That is why a case report is important. Now let's understand the strengths and the weaknesses. Coming to the strengths, as I've already mentioned, these are the real world relevant scenarios. That is close approximation to the patient population that we see in actual practice. They capture the unique patient experiences and outcome which are not seen in the larger studies. They have high precision in identifying unanticipated innovative occurrences. Importantly, there is no data analysis in case reports, improving the ease of understanding. And in case series, even if the analysis is present, it is just a 10 patients analysis, which is simple. So coming to the weaknesses, there is no causality assessment, as I mentioned, because there are no control trials, there is no cohort, so it is difficult to establish causality. Their reliance on individual cases can lead to bias. While they generate hypotheses, the findings may not always be reliable until there is a subsequent analysis. So it is important that these limitations should also be kept in mind. Another major limitation is the temporal association between the exposure and the outcome. Not always possible, because most of these reports can be retrospective, making those temporal relationship analysis difficult. Other than that, there can be a bias, because some clinicians, they can only report or publish the positive outcomes that are associated with case. Now that we have understood the basic strengths and weaknesses, let's look at some facts. That is, despite the known limitations, if you can see here, out of the 24 randomized control trials that have been done, published in the Lancet, the hypothesis came from case reports. That is, one or three case reports have resulted in a 24 randomized control trial. Coming to the landmark articles, 5 out of 51 landmark articles are case reports. This is the importance. This is what case reports play a key role in evidence-based practice. Now let's look at different types of case reports. These can be categorized into 5, that is majorly to find new disease, a new presentation, to report an ADR, a novel therapeutic approach. These can also be educational, where a new scenario is presented to clinicians to improve their practical skills, and quality assurance, where practice errors that illustrate problems, so that if they are published, we can prevent those errors. So case reports and case series can be categorized into these 5 types. Now coming to another criteria, this is also a similar one, but here we see 10 different categories. That is, original condition or a disease, and a rare or a spatially reported condition, unusual presentation, unexpected association between relatively uncommon symptoms, impact of one disease process on another, unexpected event, impact of a treatment regimen, unexpected complication, that is an ADR, a unique treatment, on honest mistaken management, which comes under quality assurance. So again, we have these different categories. Now that we have understood the definition, purpose, let's begin with how to write a case report and case series. Before we go on to write, we have to choose a novel case. I mean, it is very important. Novelty is the fundamental criteria of case series and case report. As I've mentioned earlier, it is the case that is going to be unique that to be published. So it has to add to the existing literature. What knowledge gap does this case fill is something that we have to understand before we move on to writing the case and publishing it. So, what do we have to look for in novelty? We should see again, as the criteria we have mentioned, it's the similar one. If there is any new association, a present new presentation, unique or rare management, or an unexpected event, underreported, or an unusual adverse effect, novel or useful therapeutic approach. So this is how is the basic criteria for novelty, which we have already seen in the types as well as the categories. So how do we actually find out if our case is novel? This happens when we discuss with the team. To assure that the case is truly unique, you must review the literature to determine what is it going to add to the existing body of knowledge on this topic of question, or you use a novel intervention to treat or diagnose the patient. That is the whole point. What unique are you doing in that particular case, that is to treat or to manage that patient or to diagnose that patient? Once you have identified that the case is new or unique or rare, you sit with your team and discuss the aspects of the case that you want to highlight in your publication. Prepare for the case study. Write by obtaining the patient information, including demographics, history, lab results, treatment and time course, and other information that is relevant to your course. And at the same time, to guide writing, we have to choose the journal at this point, because many journals have a lot of recommendations on how to write, how many references are they going to accept, what is the word count, or do they require the abstract constructed or in a structured way or in a deconstructed way. So all of these recommendations will help us write initially. So based on the scope of your objectives, you have to choose the journal. That should be done before you proceed to write. Although you can have an initial draft of all the collected information from the case, but while you make it a better manuscript, it is important that you choose the journal before you proceed. Another important thing that you have to do before you write is to obtain an informed patient consent. It is the primary importance that the respect for the patient's willingness and confidentiality is given importance. The patient should be explained the entire process of manuscript submission and review, ask them to sign the required consent forms. It is also advised to keep a copy of these forms that the patients have signed with the authors and give another copy to the patient if possible. And we see a lot of scenarios where the patient himself cannot talk, or the patient is a child, or the patient is not in a condition mentally to be able to process the information that we have provided to give the consent. So at that point, the next of kin or the patient's parents or relatives, legal advisors, anybody can be contacted to obtain the informed consent. Any other identifiable information, like for example photographs of the patient, if they are present in the manuscript, before you submit the manuscript to the journal, it is important that the patient or the next of kin review the manuscript for publication. So after this consent process is done, then you move to the real deal, that is to write the manuscript. So here you are looking at the care checklist, which is the one of the most useful tool for an author to write a case report. It begins with giving you the guidance on writing the abstract, how do you formulate the title, what are your basic keywords, coming to introduction, all the case, and then how do you write a discussion, what points do you answer in each and every category of writing a manuscript is provided in the care checklist. This can be a major tool for anybody who is going to begin writing a case report. So let's look at all this in detail. First one is to write an abstract. So abstract serves as a concise summary of the case reports, capturing basic information, that is what are the highlights, objectives, and the significance, enabling the readers to grasp the core insights. Next step is to write the introduction. As you see here is a funnel. This method of writing is the most easiest method of writing an introduction, where you begin with a broad information by defining the condition or the drug use or the mechanism, while you slowly narrow it to the relevance, highlighting the unique aspect or learning point of your case, like the rarity, unusual presentation, new treatment, or a toxic effect, whatever is your case dealing with, and providing sufficient literature to establish context and importance, keeping it focused to attract the reader. So it is not necessary that an abstract has to have references, but introduction should summarize the existing literature and put out what novel are you adding to it. So introduction should have references. Coming to methods, methods is not generally required in case reports, but you may need to write methods in case series, like mentioning the number of cases that you have included, providing the context and scope for the reader, ensuring reproducibility in future studies, and time period, that is the specific time period over which the cases were followed, and inclusion criteria and diagnostic criteria. A brief mention of this will help the readers understand how many number of patients you have included in the particular case series. And coming to the major part of our case report and case series, which is the case description. This section provides a detailed overview of the course, beginning with the demographics, that is the patient age, gender, relevant clinical characteristics like comorbidities, drug history, all of those. And then you relate it with the lab values, that is the initial presentation of the patient and the diagnostic approach that is done through basic laboratory test, and how did you arrive at that particular diagnosis. Based on the diagnosis, how the treatment approach has been chosen and what outcomes did the patient have, all of this should be mentioned in chronological order. This is the entire crux of what novel thing are you trying to put out. It should be mentioned in the case description. So here is a brief mention on when you're trying to report an ADR. You should also mention clearly the dosage administration, that is which route the drug is administered, and the regimen, and the clear duration. If possible, if there are any blood levels, if there is a toxic effect, or if there is a suboptimal dosing, whatever it is, or if there's a drug interaction resulting in increase in the drug levels, all of this should be backed up by evidence if there are drug levels reported. And coming to what a pharmacist can report, here is the example that I wanted to give you all, which is a quality assurance case report, where a weekly methotrexate dose was administered daily, resulting in multi-organ toxicity. Reporting such cases will create awareness among clinicians to keep a check on how the patient is administering the drug, and how important counseling is to make sure that the drugs are taken appropriately. Another great tool that can be used in adverse effect reporting is Naranja scaling. As we know that ADRs are common, it has been estimated that 3 to 8% of hospitalized patients are admitted because of ADRs, and about 7% of hospitalized patients will experience a serious ADR during this stay. And the problem with ADRs, that is drug induced adverse effects, are mostly the diagnosis of exclusion. That is where these causality tools come into play. Here is our Naranjo scale where we use these 10 questions to assess causality. We assess the temporal relationship, effect of re-challenge and de-challenge using the score. If we all know that if a score that is between 5 to 10, it is a good score showing that the adverse effect is probable and highly probable. And again, we have another important score for the drug interactions, which is a drug interaction probability score, which is again a checklist of 10 questions, which will let us know how probable is the drug interaction. Let me give another example where the authors have used de-challenge and re-challenge as a method to identify causality in this initial case report of linezolid-induced lactic acidosis, where there were no drug levels to identify the effect. But once the drug was de-challenged, it resulted in normalization of lactates within 2 weeks. And after the drug was re-challenged, again the lactates elevated. This is how they understood that it was linezolid that caused lactic acidosis. However, they did not know the mechanism. This is where the hypothesis was generated, and clinicians started to look for what could be the possible mechanism associated with lactic acidosis in linezolid. And now we have arrived at our one of the mechanisms that is underlying the toxicity is mitochondrial toxicity. This is how a first initial case report where we don't know the mechanism, but we know that it is causing it through our causality assessment, resulted in understanding the mechanism behind the toxicity. Next part after you have described the case is to discuss the case, which is to intervene in middle and then tie your case to the existing literature by answering the 4 questions. That is, how is your case different, and what are the key findings and differences from the existing literature? How will it change the management of the future cases? Like, for example, we have seen the linezolid case. Now that we know that mitochondrial toxicity is the cause, and they have created awareness. Now we know whenever a patient is given linezolid, we have to monitor lactates and we have to make sure that the drug is appropriately de-challenged whenever you see elevated lactates. That is how the cases can change management and what further research needs to be done. These are the 4 different points that a discussion should address. Coming to figures and tables, they play an important role in simplifying data presentation. Like you see here, a figure that these case report of cefditorin induced toxic epidermal necrolysis has been published, where different criteria were utilized to evaluate the causality. Again, severity of illness score for toxic epidermal necrolysis. This table clearly shows us that the patient has a higher score and then the predicted mortality is also high. Again, they show a figure here where the patient face is not identified to show respect to the patient and maintain confidentiality. This is how figures and tables had an integral part to the case, detailing the case and providing us a visual representation of how the patient presentation was. Coming to the references, this section is a clearly important part where you have to adhere to the journals requirements and the style of references that is required by them, like Vancouver or Harvard or any other style that is required, because formatting is something that alters the decision of acceptance or rejection by a journal. So it is important that you adhere to the guidelines that are provided. And in conclusion of your case, you're going to summarize all your key findings and how your case is going to add to the existing literature. And coming to the last but not the least point, that is authorship and acknowledgements. Uh, the ICMJE recommends authorship criteria, which is the four criteria, where all the four criteria should be met for them to be called an author, where you have to have substantial contributions to the conception or design. You have to initially draft the work, finally approve, and then agree to be accountable for all the aspects. If a contributor does not meet all the four criteria, they can be given acknowledgement but not authorship. So, this has to be kept in mind before you give authorship to anybody who has contributed to the case. And then comes to the submission. Now that you have formatted the case, you click the submission button. But what happens after submission, after you choose the right journal? And that is, your article will undergo a process of editorial assessment initially, where the editor will go through your briefly your abstract, looking how novel it is, and then if the editorial check is done, that is if the editor wants to process it further, you will navigate the peer review, where independent peer reviewers will go through the entire manuscript and then decide if they accept your publication or not. This decision will be sent to the editor, and the editor will choose to either accept, reject, or revise. If you are advised to revise the manuscript, different peer reviewers will provide you recommendations on what aspect of your manuscript should be changed. You can agree politely or disagree politely and then provide the revised manuscript again to the journal so that it get published. So it is a very long process, and it requires a lot of patience. Although case reports are easy to publish, but they can be a little bit time taking because of the entire peer review process. And then now that your article is published, this is the normal critical checklist that you are going to use to evaluate any case report or a case series for documentation, educational value, interpretation, objectivity, and uniqueness out of a score of 10. This is how a published case report or a case report that you are going to publish should be critically evaluated. Thank you.
Thank you, Amartya, for a clear and informative session. So now I think we will proceed for the Q&A and interactive sessions. So I request all the participants to post their questions in the chat box. So we'll be taking them up one by one. I encourage everyone to actively participate and clarify any doubts related to today's topic. Like I had some doubts. Like first, we can discuss that one part. Like Amatya, can you just tell me at what point in clinical practice should one start documenting a case for possible publications? So, like even after the discharge, should we start collecting the data for the case report, or else in the start of the admission of the patient, that time only should we start the data collection? So, like, can you clarify on this part?
Yeah. The point that you will start beginning data collection is when you know that the case is novel. I mean, when you know that it is something that you haven't seen before, that when you approach a case, you will understand with your existing knowledge that this is something that I have not seen before. So you look for literature, you go in different databases, you search that this case exists. If you think it does not, that is when you discuss with your team. See that I have seen particular case when I was in the round. Do you think a case like this exists, or do you think a treatment adverse effect that has happened, does it exist, or how do we know that this is novel? Once you do that, that is the critical literature review part. That is when you understand that the case is novel. At that point, you'll start beginning the data collection. It could be when the patient has just diagnosed, or the patient has just sent the laboratory reports, you are awaiting the reports, whatever the scenario is. Now, when you know that the case is novel or it adds to existing literature, that is when you start taking the notes. However, you have to follow the patient to see that outcome. We don't know how long we have to follow. That is a tricky part, but most people, they just tend to select the patient but don't collect the data yet. They will retrospectively collect the data. That can be a little bit what do you call that, tricky, because you can lose some data when it becomes retrospective. But yeah, this is what exactly happens when you're writing a case report. You just identify the case, you follow the patient through his outcomes, and along the process you collect the data. And most of the times in the hospitals we have electronic medical records, so it doesn't it isn't as difficult as to collect data through these electronic records as the paper ones. So yeah, that is how it happens.
Thank you, Amatya, for clarifying my doubt. And I think we don't have any much questions in our chat box for now. So if you are having, if any participants are having any where we are there, we'll be answering those questions. So, thank you so much, Amatya, for this session. On behalf of the Clinical Research Forum and FCI, I sincerely thank you for sharing your knowledge and expertise with us today. I also thank all the participants for their active presence and engagement. Thank you.
Yeah, thank you.